my pleasure to introduce Dr. Troyen Brennan. Dr. Brennan is the Chief Medical Officer of CVS Health and an intellectual. Dr. Brennan completed medical school and earned an MPH at Yale. In his spare time, Dr. Brennan completed law school at Yale and previously was a Rhodes Scholar, earning a master's in political economics at Oxford. For 15 years, he was a professor at Harvard Medical School, where he led the Harvard Medical Practice Study that is the basis of today's hospital safety movement. Dr. Brennan and his colleagues showed that adverse events occurred in 4% of hospitalizations, and that 1/4 of these adverse events were due to negligence. Dr. Brennan was the president of the Brigham and Women's Physicians Organization and the chief medical officer of Aetna before joining CVS. In 2014, Dr. Brennan led CVS to be the first retail pharmacy to ban the sale of all tobacco products from its stores. Last year, he was instrumental in CVS Health's acquisition of his former employer and one of the country's largest health insurers, Aetna. A decade earlier, he had described CVS's acquisition of the pharmaceutical benefit manager, Caremark, a fascinating move. Now all eyes, including those of Walmart, Humana, Amazon, JP Morgan, Partners Healthcare, and Berkshire Hathaway are on CVS Health. Today, our eyes are on Dr. Troyen Brennan, the keynote speaker of the 2018 d.health Summit.
Thank you very much. That was a very nice introduction. So the clicker, the omnipresent clicker. So I was going to talk a little bit about retail management of population health, and this is about a half an hour presentation, but I'm going to cut it down to about 15 minutes because it seems like it's a small enough group that maybe sort of take some questions and things like that. The idea is to try to think about sort of what a new chassis would look like for population health management, and that's what's behind our proposed acquisition of Aetna, which has not been approved by all of state and federal authorities yet. So I like to start usually with a bunch of sort of empirical slides, but I don't really have time for that. But I think this was a very illustrative. If you look at sort of all non-elderly households, just the top portion there, I can actually see it a lot better than you can because I don't have the glare. But what it shows is that about 40% of all non-elderly households have less money basically in the bank than they owe on their deductible or could owe on their deductible. And looking at sort of information about how our healthcare system is sort of in trouble, I find these kinds of financial slides to be the most indicative. And what we see is just a healthcare system that is basically pricing itself beyond our reach. And a host of factors, most recently the Tax Cut and Jobs Act, but also the aging of the population, are going to make that sort of ever more clear that we have to come up with sort of new ways to manage healthcare costs. And if we don't, then there's just going to be a lot of people who can't afford health insurance and a government that can't afford the responsibilities that it has. So our approach is a few sort of words here, and this is all based on the fact or hope that we would be able to acquire Aetna and then set up a chassis that would be used not only for Aetna members, but also that we would use so-called open source and be used by a number of other insurers as well. But it'd be a unique chassis for population health. And what we're trying to do is take, and I'm sure you had a lot of discussion about this today, the data that's available, the manifold data that's available, and process that appropriately so that we can identify patients who are in need and then address that. So it's got a strong foot in a digital base, but the other part of it is face-to-face. And we have 10,000 locations all across the country. We have about 35,000 healthcare workers who are prepared to help people out on a face-to-face basis. And the workers that we have are pharmacists and nurses. They're the most trusted professionals in healthcare, and they also have the best sort of listening and advising skills available. I don't know if everybody really wanted to see the slides more than they wanted to see the gorgeous day out there, but there it is. So the whole idea, if I had to say, is there are 3 words on the slide: new chassis, and then digital-based, digital intelligence, and a human touch. That's what we're trying to combine with what we're doing. And this is a slide that would normally animate, but it doesn't on this. And the left-hand side of it would be a traditional approach where you've got a patient who's talking to a nurse case manager over a telephone. About half the time they don't have the telephone number. And then 90% of the time, the telephone's going off in somebody's house, and if it's like my house, nobody ever answers that telephone. So it's a method that a lot of us have used over the years, and I was in health insurance. I was actually the chief medical officer at Aetna for about 3 years, but we feel like it's kind of broken. And so if this animated up, what it would show you is that we're going to put the patient basically at the center of things, but we're going to be offering them not only traditional telephonic approach, but also a digital virtual approach, as well as the ability to consult with a nurse practitioner at a Minute Clinic or a pharmacist at a CVS pharmacy. So the whole idea is to use digital information that comes in, set up an event engine over the top of all that information, identify where interventions have to be made, and then activate all 4 of these elements. And you'll see also probably trying to transfer that over to the primary care provider. So here's what it looks like when it does animate, to give you a sense about how it is. We're trying to put the patient at the center of a system that's not just telephonic, but is also heavily digital and heavily face-to-face. So that's the way we're looking at it, and we think we can improve engagement levels doing that. That's the key thing you're looking for in any of these jobs where you're trying to manage healthcare. That is, do you actually have the patients engaged? And as you who are in startups know, and those of us who are sort of talking to startups about the work they're doing, critical element is engagement, and that's what we're aiming at here. So I guess the question would be, how will we go about doing this? And I try to break it down relatively sort of simple so that there are a few things you could take away. We have 3 targets, and then we have 4 major tools. And I'll talk about the 3 targets first, and then talk about the tools that we'll use, at least at the outset. And there's a lot of other things that we could add on to this. The first, let me go backwards, I'm sorry. So the first target is 5 common chronic diseases. The second target is the fragile patient. The third target is missed transitions, either into an emergency department or out of the hospital. So if we talk about each of those, first of all, the 5 common chronic diseases: diabetes, hypertension, hyperlipidemia, depression, and asthma. So we see about 60 or 70% of total costs being around these diseases. They're great for us, at least the pharmacy benefit management and retail pharmacy sides of the company, because they're all treated with commonly available medications that are generic, that are inexpensive. And the critical thing is getting people to take their medications. If you can get people to take their medications and get people to sort of seek care for these things, then you can overall lower costs. And you can see the estimates that we have on the slide here about what the lower costs look like. The other good thing is that they all have very simple biometrics that we can either check in a store very easily, or that people can check at home. And I'll talk about how we want to try to own the home as well. And there's very specific outcome measures. We know if we address those outcome measures, people will lead better lives. They'll have less comorbid diseases, they'll be healthier, and overall their health care costs will drop. And down at the bottom, you can see some estimates about what we think initially we'd be able to get from an engagement of like 100,000 case life just by looking at these chronic diseases. The other thing about these is that you want people to take their medications, so we're in the process on the PBM side of developing programs where there's no out-of-pocket payment whatsoever for all the medications that are used to take care of these patients. And we think that that's cost effective because of the adherence boosts that you get from that. So 5 common chronic diseases. Then the second thing is the fragile patient, and this is where the data layer comes in. We think that with more information coming in from a patient's home and more information that's available from an electronic medical record, we're heavily dependent on an Epic electronic medical record that we're basically sort of moving throughout our organization, but EMR data as well as claims data from the pharmacy and the health plans, that we can better analyze that information now than we would ever been able to do before. And that as a result of that, we can identify the patients who are going to need help early and then intervene with them. We also want to be taking advantage of information coming in from people's home, because we think that there is going to be a new set of algorithms based on monitoring information that'll help us predict about a patient who could be in trouble and then intervene early. And we also feel like one of the things we're doing is trying to close the distance between the healthcare system and the patient's home. You know, if you think about the sort of hospitals here, and you can see them all from the windows of this building. I've got a funny story. I know I was going to go slow, but I had a patient, I see patients down, or have seen patients down at the homeless shelter that's near my house in the South End. And I had a patient one night, I saw him the following day, and that evening he'd been drinking. He's homeless and he's an alcohol abuser. And he had fallen and hit his head, and he had blood on his head, and he was found in one corner of the Boston Common. Well, that corner of the Boston Common, the EMTs actually take you to the Mass General. About 4 hours later, he was found in the other corner. It's a triangular common. He's found in the other corner. That one goes to Tufts, and lo and behold, 3 hours after that, he was found in yet the other corner that goes to BMC. He had 3 CT scans that evening, all of which were normal. And only in the American healthcare system can you kind of see that kind of thing happen. But the point I wanted to make is that basically the hospitals are relatively sort of isolated from where the people are, and where we feel like we are with CVS and our CVS locations is out in the neighborhoods, and that can be a very important part of sort of closing the gap with these patients who are fragile at home. So we want to take care of them. And then the last one, and this would also animate, well, better look at it sort of this way, is that we feel like we can be in touch with people and try to make them get to the right place, help them get to the right place when they need care. So we've recently taken advantage of a new program called d.health, which has artificial intelligence associated with it that helps people decide what kind of care they need. We think that's only the beginning of being able to sort of communicate with people on a digital basis. And then a certain number of people who are going to the emergency department today don't need to go there. And so we're going to ask them to go to our retail clinics, which are expanding in the direction of doing more urgent care. And then when they come out, we published a paper about 3 years ago in Health Affairs demonstrating that we could reduce readmission rates by 50% simply by doing a complete medication review for a patient as they came out of the hospital. Most patients who go out of the hospital and then go back in the hospital on a readmission basis never see or talk to any kind of healthcare provider. So we would have them stop at the CVS on the way home, go over things with nurse practitioner, go over their medications, and try to prevent them from going back into the hospital. Again, there are very substantial savings associated with that. All of this is just pure waste. It's pure waste when somebody who goes to the emergency department doesn't need to be there. And it's absolute waste when somebody goes back into the hospital after they were discharged. Now, that's the 3 targets. So it's the chronic diseases, the fragile patients, and the missed transitions. The 4 tools, I've already talked about most of them, but the first tool is the store. We'll have coordinator, clinic, and pharmacy visits available. The second tool is enhanced digital and telemedicine outreach for individuals. The third is going into the home with biometric devices and so-called owning the home. And the fourth is connectivity to the providers, and I'll talk to them briefly. And again, another point to take home, in addition to sort of new chassis, digital platform, face-to-face, the other one is that we're shrinking the distance between the individual, between the patient's everyday life and the care that they receive, the engagement with the organization. So the tools that we would have would be basically in the store. We'll be redesigning our stores. We're in the process of redesigning our stores. There's more and more space available as more and more of our front store sales go to a digital basis, and that we're taking advantage of by layering in new services. Even before we began to talk about acquiring Aetna, we were putting in audiometry, optometry, we'll put in more lab services, take a hard look at radiology, all those kinds of things. But we'll have clinicians there who are on the Epic electronic medical record, and they'll be taking advantage of algorithms that are running on this data layer that we have on individuals and looking for places where they can intervene with regard to gaps in care or advice about preventive medicine or specific things around adherence and taking their medications appropriately. So that's basically the coordinator, the pharmacist, and the Minute Clinic nurse. And as I said, we'll be putting infusion in the stores. We've recently announced that we're going to get into home hemodialysis, so there'll be support for that program. A whole host of different kinds of things that you can do in a neighborhood location that's convenient for individuals. I always say that we're not great strategists at CVS, and this is really my major strategy slide, and all it does is sort of show a store, but more importantly, you can drive up and park and get in it easily. And everything I've learned about behavioral economics over the course of the last 15 years is that convenience is the #1 issue. And so that's what we're trying to take advantage of. The fact that we have these practitioners who people like to see, and we have the ability to engage with them in a convenient basis. With regard to digital medicine and telemedicine, I think I've talked about the digital layer for analysis. We also have just recently announced our collaboration with Teladoc on telemedicine. We believe that more and more people are going to be seeking care on a telemedicine basis, and that we need to make that available, both mediated by us with doctors, but also telemedicine visits with our nurse practitioners and with our pharmacists, and with a real evaluation of what's going on with both telepharmacy in addition to telemedicine. So you can see at the bottom, if we develop an artificial intelligence diabetes assistant, for example, and those programs are very well developed out there right now. If you're texting with your bot today, you would have no idea you're not texting with a diabetes educator. And see a patient who's got rising blood sugars, we can do a telemedicine consultation and then bring them easily into the store to make sure we get the appropriate face-to-face care, right prescriptions, and those sorts of things. So we think that the convenient location linked up with this sort of digital telemedicine approach is the way to go. And then the third step from an electronic point of view is basically at the home. And we've seen a lot of different changes with regard to sort of monitoring people at home. But I think most striking, it was only a decade ago I was a chief medical officer at Aetna, and GE and Intel had me out to a house that they had all wired up in Portland to show me how, and it costed like $30,000 to wire it up. That's $30 today to get the same information. So we believe inexpensive, widely available information is going to be coming in from the home. And quite frankly, the doctors, the average primary care doctor you talk to, they're like, no mas. I can't take any more information coming from this electronic medical record. The last thing that they want is all this information coming in from the patient's home. But that's the kind of thing that we can take and process and then address. And our nurse practitioners, when they're not seeing patients, they can be on the phone with people who look like they're having some early signs of distress at home. So owning the home is going to be really important. And then the last thing I say is that the really important thing for us is connecting directly to the providers. We see ourselves as providing complementary care, complementary primary care, not primary care itself. We think everybody needs to have a primary care provider, but we do believe there's a lot of things we can do to help the primary care provider. And this is just an example. A patient with a PCP has hypertension and diabetes. That doctor refers the patient to us. We basically see the patient, get them started on medications, tune them up, do the biometric monitoring, do all the laboratory data, and then send the patient back to that practitioner. In a fee-for-service world, the practitioner might not be interested in that. In a risk world, the practitioner is very interested in that. And so that's kind of what we're preparing for. All that information is going into the electronic medical record, and then we're sharing it. We're already sending our notes from Minute Clinic to over 20 electronic medical records. We have those electronic connections built. And I think that's a difference kind of to where we are. This just shows our interoperability statistics, which are quite good. We're, in fact, the biggest provider on interoperability by far in the Epic system. We exchanged 4.6 million records last year. Our commitment to primary care, we referred 3.2 million people to new primary care doctors last year. So we're very committed to primary care. In this model, there's really two ways to go about this model. One is to, if you're an insurance company, buy a whole layer of primary care and buy ambulatory surgery and buy urgent care. So you own an entire layer of primary care and then kind of play the hospitals and specialists off against one another. That's a model. That's kind of an old model. That's not one that we're pursuing. What we're pursuing is one in which we're providing complementary primary care, basic preventive primary care, things that we're really good at, that quite frankly the primary care doctors are not as good at, making sure people take their medications, making sure that they're checking their blood sugars and things like that. That's what we want to do, and then work directly with the primary care doctors and with the integrated systems. We want to support the medical home, and we want to support the accountable care organization. So it's a different approach, and that's why we call it complementary primary care. So to summarize, if I had take-home points, fuse digital engagement with convenient, focused one-on-one care. That's the main thing I'd say. reduce costs by improving quality and individual quality of life. The critical thing about what we do, and it's best captured by adherence, is if people take their medications, they have less illness, they feel better, they're better able to sort of interact with their community and with their family and to live strong lives, and the costs are reduced. And that's what we need to do, is reduce those costs. We want to support accountable care organizations and medical homes. We want you to understand that our infrastructure that we're developing is going to be sort of equal parts integrated, AI-evaluated data, and physical space at convenient locations. So that's kind of what we're aiming for with regard to retail health management. Let me see if there's some questions.
Great presentation, and very exciting to hear what CVS is doing. I think one thing that jumped out at me in the beginning is you talked about the challenge of reaching patients and the notion that nobody really answers a phone anymore, and maybe they don't have a telephone number that can be reached. How do you then make the leap from that to digital, which is far more sophisticated? Patients may not have access at home. Smartphones are more pervasive, but not fully pervasive. Can you address that?
Well, smartphones are more pervasive. Nothing's going to be fully pervasive, but they are more pervasive. And a lot of people are sort of much more engaged with text today than they are with their telephone. Look, we think of ourselves as the #1 by far users of telephones to communicate with people. If the phone's ringing at my house, it's most likely the CVS pharmacy calling me about the fact that I haven't picked up my medication. So that we do. And when we interact with a health insurance partner, what we find is that we can basically double or triple the number of accurate phone numbers we have, because we need that phone number, and we're assiduous about getting it when people come into the pharmacy. We're moving in the direction 5 major metropolitan locations today, and by the end of the year across the country into basically either next day or same day delivery. So fewer and fewer people are going to be coming into the pharmacy itself, so it's going to be imperative for us to be able to sort of have that information that we need to communicate with them. But the critical thing here is, I think, sort of identify people where they are. What characteristics of an individual is going to tell us we're better off trying the phone, we're better off trying to text, we're better off trying to get them into the pharmacy to sort of speak with them. That's what I think everybody's kind of chasing today. But we at least have promise. There's always promise in this area that we're going to be able to accomplish that better than we have before by smarter analysis of data.
It's a great presentation. Where do you expect to set the dial on nursing services such as phlebotomy? I'm curious about that. That seems like for CVS in the past may have been a bit of a break point in terms of lab work.
Yeah, I think the way we're looking at it is, and we're experimenting this with the major labs, and both of the major labs used to have sort of exclusive arrangements, one with Aetna and one with United, but now everybody's sort of working with everybody else, is good from our point of view. But basically, we're bringing MAs, medical assistants, into the clinics now, who will do the blood draws and get paid by the labs themselves and then send the labs off. We also are, maybe we're positivists, but we also believe that technology is going to be there for a much broader range of tests that can be done on capillary blood. That'll be, so basically sort of finger stick, real-time, point-of-care information that's CLIA waived. So we don't think that notion kind of died with the Theranos story. We do think that there are other opportunities for accomplishing that, and we think that's a big, big change for us, because if we can get, basically you think about it, if we can get a CBC, a basic set of lights, BUN and creatinine, right there while the patient's there, then that revolutionizes our ability to take care of hypertension, for example. Just having a BUN, creatinine, and a potassium right there at the time you see the patient, you adjust the medications, and you're good to go. So we think things are moving in this direction, sort of more convenience and quicker, and that's where we'd like to go. But for now, we'll use the standard sort of LabCorp Quest approach to be able to get the medications.
For those individuals who don't have primary care physicians, you had mentioned referral to a lot of primary care,
Yeah.
or maybe referral back.
Yeah.
How do you determine who you're referring to out of
We
the
maintain
CVS
a
location?
we maintain a very active list of primary care doctors who are taking patients in the areas surrounding our clinics, And you know, on a 6-month basis, we reperuse that list and make sure that the doctors are still taking patients. And then we send people there. We work with about 80 different integrated delivery systems. And although we can't, because of the federal law, you know, sort of say, go to these people, we do include them on that list, and we make sure that we get the information directly to those individuals. So that really hasn't been a problem. I think that there'll probably be, I also believe, and you know, I knew more about Aetna before we decided we were going to try to acquire them. Once you try to acquire them, you basically have to be sort of hands-off until the acquisition actually sort of goes through. But they've been public about the fact that they've gone deep with 5 or 6 integrated delivery systems. I think Cigna's got a slightly different approach than that. They're much more widely spread. And then United's kind of building things themselves. So everybody's got a slightly sort of different approach, but I think you're going to see more collaboration between the organized physicians and the health insurers going forward. You can't imagine how we're going to squeeze costs out unless you get better collaboration in that regard.
Just had a quick question. The nurse practitioners now, it's my understanding, work very much in sort of an algorithmic fashion. Will that be true with this expansion, with these other diagnoses that you're going to be targeting?
Our nurse practitioners are on algorithms on the electronic medical record, and it greatly increases the sort of adherence to evidence-based guidelines. So in the states that track that, in Minnesota, for example, MinuteClinic outperforms the Mayo Clinic year after year in terms of adherence to evidence-based guidelines. And those guidelines are equally applicable to most of the chronic diseases we're talking about here, for example. So, you know, we've used Heart Association or ACC guidelines for how you're supposed to treat hypertension, and, you know, ADA guidelines for diabetes. So that's relatively sort of algorithmic driven. We are moving in the direction with a couple of integrated delivery systems that operate their own insurance companies to become certified primary care providers in those particular circumstances, and that will require sort of more clinical judgment. But nurse practitioners are trained to do that. You know, in rural areas, over 50% of the care. In Medicaid population, over 70% of the care is being provided by nurse practitioners today. So we think that the nurse practitioners are going to be able to do a really reasonable job in terms of moving up as we expand services. The other thing I'd say about this is that, you know, with information that comes in from this algorithmic-driven analysis of a big data layer, ever more sophisticated gaps in care can be analyzed, and then that information provided to the pharmacist and nurse practitioner. So if you like, we're kind of raising the ceiling on the license, and everybody says that you need to have these practitioners practicing at the top of their license, but the technology actually enables you to increase the height of that license, as it were. Yes.
Thank you so much for your presentation. I'm actually a pharmacist, so it's nice to hear a lot of great things that CVS has done. Mm-hmm. We actually just graduated from Yale MBA, so we talked a lot about the CVS and Aetna merger. Mm-hmm. Just want to get your take on how you plan.
We talk about it a lot too.
Yes, we. And we're just wondering, what's your take on how do you plan to capture the synergy from that merger, and what are your concerns with it? We're allowed to talk about it.
Well, I mean, the synergies are basically sort of what we've been talking about here, which is that, you know, at least from our point of view, from my point of view very specifically, I'm very interested in doing population health management in the stores and with the pharmacists and with the nurse practitioners. But it's hard to invest in that kind of thing unless you've got an at-risk population, because otherwise we have to develop it and then we have to sell it to our health plan clients. We have tons of health plan clients on the PBM side, but we'd have to first develop the entire thing for them. The big thing about acquisition of Aetna is that you acquire 2 or 3 million Medicare Advantage lives and 5 or 6 million fully insured individuals, and then you've got the sort of business case for developing these things, and you can jump on it, and then you can make that available sort of on an open source basis. There's going to be places like Louisiana where, you know, we're trying to develop a relationship with Blue Cross Blue Shield of Louisiana. On our pharmacy benefit management side, they probably got a 70% share there. Aetna's got a 2% share. So in those particular circumstances, you know, we'd be working with, if we can convince Blue Cross Blue Shield of Louisiana that this is a good model for improving quality and lowering costs, that they should take advantage of it, then the open source really comes to life and you begin to sort of spread this throughout the country. But you need that initial push from owning your own risk, and that's what the Aetna acquisition is about, at least from my point of view. You can see our public statements for the synergy issues. Can I take one more question? Whoever's got that
Yeah.
mic. Yes?
Quick question.
What was that?
Thank you for the presentation. The question is more about population health tools. So ACOs are building their own pop health tools. You have your own framework for big data and population health. Hospital systems are doing something similar.
Who is?
Hospital systems.
Hospital systems, yeah.
So how are you coordinating the kind of care and among all of these entities that are also trying to drive care at the patient's home or trying to reach out to the patient as a part of their existing bundles or existing risk contracts? So it's a little
I
bit
mean, from sophisticated contracting, I guess, is the answer to that. Whoever does it best, you know, and I think what you have to do is you have to have, you know, this data layer we're trying to develop is the easy thing. The event engine standing above it and the coordination between like several different apps that we're operating and several different intervention programs we've got, and then the ones that our partners are operating. And in Dallas, for example, if we're working with Texas Health Resources, for example, you know, are they going to do the care coordination or are we? If they are, then we're basically going to turn off our systems and turn it on for them and make sure that the systems are smart enough so that they can articulate and coordinate. The thing that everybody wants to avoid, and what you really do have to avoid because it occurs, is 8 different people from the same organization calling up the same patient with diabetes and trying to talk to them about certain aspects of their diabetes. So a lot of it's IT, and you hate to say that because especially when you get to be my age, you realize, you know, sort of how long everything takes with IT. But I think that the opportunity is there and increasingly there with the sort of subtle agility that's available in systems today. Okay, well, thank you very much for having me.